second, and I will pull up our slide deck. All right, can you guys see that okay?
Yes.
Awesome. So, good afternoon. Thanks for joining us this afternoon for our October Georgia PQC maternal webinar titled Maternal Cardiovascular Health in the Fourth Trimester. Before we get started, just a few housekeeping items we like to always go over. Please make sure you mute your lines during the webinar to avoid any interruptions. Reminder that this webinar and past webinars are housed on the GAP QC website for review at your convenience. They are located under the Maternal tab. They're also available on DPH's YouTube channel. We should have a few minutes for questions at the end of the presentation. Feel free to type any questions into the chat if you're not comfortable coming off mute. If for some reason we do run out of time and you have a question, feel free to email us at gapqc@dph.ga.gov and we'll get back to you. Quick reminder, if you have any new staff or leads or champions that need to be added to the listserv, please send those to me at amy.mock@dph.ga.gov. We'll be happy to add those, and that way they receive activities such as the webinars, office hours, newsletters, updates, things like that. And again, thanks for joining us today. Just a few of the updates we like to go over each month. Our next GAP QC maternal webinar is scheduled for Tuesday, November the 5th at 2 p.m. with Christy Gable from California as the guest speaker. She'll talk about measuring and communicating blood loss during OB hemorrhage and the why behind that. Simple QI, our new data platform, is up and running. If you're having any issues accessing the site, creating your homepage, or assigning roles, please let Jennifer Bolin or myself know as soon as possible. We're happy to walk you through that, resend that link, whatever we need to do. FY24 Quarter 1 outcome data for hypertension and cardiac have been uploaded into Simple QI if you'd like to take a look at that. And then a reminder that our FY24 Quarter 3 data submission for July through September will be due October the 31st. The next AIM TAP webinar is scheduled for Thursday, October the 17th at 3 p.m. Eastern Time. The topic is postpartum discharge transition, and the link is on the, I'm sorry, I did that too fast. The link is on the screen here if you're interested in participating in that. We recently provided 100 seats for the Institute for Perinatal Quality Improvement Birth Equity modules. If you access the modules using the promo code, please complete all 4 of those modules as soon as possible. Once all modules are completed, you will receive C&E credits for that. And completion of the health equity modules will improve your facility's commitment to AIM's 5th R, which is the respectful, equitable, and supportive care. You'll be able to utilize this training opportunity as it relates to meeting process measure 4 and structure measure 5 for those of you participating in the cardiac initiative. GAP QC continues to recruit for our Wave 3 participation as a learning or active cohort for the Cardiac Conditions and Obstetric Care Patient Safety Bundle initiative. If you or your facility are interested in starting Wave 3, we plan to begin that in January of 2025. And if you'd like more information, please reach out to me via my email address. Some upcoming resources opportunities worth sharing include the Georgia Heart Institute will have their grand rounds on Wednesday, tomorrow, October the 2nd at 7 a.m. with guest speaker Dr. Ashbin Hamid. Dr. Mead is triple board certified and a leading expert on maternal cardiac risk in the U.S. Feel free to join the grand rounds by Zoom, and we've added the QR code on the screen here. DPH, is currently undergoing our 5-year needs assessment for the Title V Maternal and Child Health Services Block Grant. This is done to guide the development of our state action plan. We'd love your help in getting this survey out to the public for their input into public health services that impact women, infants, children, and families. Please share with your patients, friends, family, or any social groups you're a part of. You can use the QR code on the screen, and I'll send out the flyer in a follow-up email. We appreciate you sharing this widely. Mama's Voices and AIM Community of Learning has classes for hospitals that will begin a new 4-week program on Tuesday, October the 7th. If your facility is working to address respectful, equitable, and supportive care as part of your quality improvement work, this is a great opportunity with excellent resources to assist. The community of learning incorporates people with lived experience and ways to effectively build a patient engagement culture and perform work that integrates patients and their support systems into perinatal work. And for more information or to secure your spot, you can use the QR code or use the email address there on the screen. The next obstetric patient safety workshop, hosted by Hope for Georgia Moms, North Georgia Health System Center for Simulation and Innovation, and A1, will be October the 24th. This is a wonderful opportunity to enhance skills in managing OB emergencies through simulation and debriefing. If you're interested in participating in this free workshop, contact Tasha at the email address on the screen. And last, before we introduce our speaker today, we always like to show our maternal cardiac conditions key driver diagram and remind you that our goal is to reduce severe morbidity and mortality related to maternal cardiac conditions in Georgia. And our SMART aim is by February the 6th, 2026, which is known as National Go Red Day, to reduce harm related to existing and pregnancy-related cardiac conditions through the 4th trimester by 20%. And our key drivers are the 5 R's based on the AIM Patient Safety Bundle. And then we have all of our interventions listed here with our structure and process measures intertwined in that. So without further ado, I'd like to introduce our guest speaker for today's maternal webinar. Please help give a warm welcome to Dr. Jennifer Louie. Dr. Louie is a cardiologist, the director of the Penn Women's Cardiovascular Health Program at the University of Pennsylvania Perelman School of Medicine, and the co-director of the Pregnancy and Heart Disease Program at the Hospital of the University of Pennsylvania. She completed her internal medicine and pediatrics residency at Brigham and Women's Hospital and Boston Children's Hospital, and her adult cardiology fellowship at Columbia University Medical Center in New York City. She also has an MPH in clinical effectiveness from the Harvard T.H. Chan School of Public Health. Her research program focuses on 2 major areas broadly related to maternal cardiovascular health: improving outcomes and reducing racial disparities among pregnant and postpartum individuals with cardiac disease, as well as reducing the burden of hypertension and cardiovascular disease in individuals with adverse pregnancy outcomes. Dr. Louie's research spans health services and clinical research methodology, and she has experience in behavioral and pragmatic clinical trials and qualitative and mixed methods research. Dr. Louie will speak to us today about maternal cardiovascular health in the 4th trimester. So please help me welcome Dr. Jennifer Louie. Give me just a second, Dr. Louie, and I will stop sharing my screen.
Great, and I'll go ahead and share my screen. Okay, can you all see my slides, the normal appearance of my slides?
Yes, ma'am.
Yes. Okay, great. Well, first of all, thank you so much for the kind introduction and the warm welcome. I have to say it's really a privilege and an honor to speak to you all today. I know that you are all committed to improving maternal outcomes for people during pregnancy and the postpartum period, and to feel like I can be a small part of your work in improving cardiovascular outcomes is really an honor. And so my goal today is to really have an evidence-based but clinically focused talk on cardiac complications that occur after delivery in the what we often call the fourth trimester. Teams is an interesting beast, and so I can't really see anybody or see comments or questions. So if there is any burning questions during the presentation, feel free to come off mute. Otherwise, we'll have some time at the end to go over questions. And so just conflicts of interest. So I do receive research funding from the NIH on this topic I'm talking about today. And I will be talking about something called the Peripartum Cardiomyopathy Registry, which is unfunded. And I receive some consultant fees from Amgen, but unrelated to the topic discussed today. And so our objectives for the next 40 minutes or so is to review the leading causes of pregnancy-associated mortality in the US, to review the causes and evaluation of cardiac symptoms in the postpartum period with a specific focus on shortness of breath and chest pain, and to improve our confidence in screening for postpartum complications, specifically related to what I like to call the 3Cs: cardiomyopathy, coronary syndrome, and clot, short for pulmonary embolism. And throughout the talk, I'll have a few clinical pearls highlighted in blue boxes just to draw your attention back to the topic. To this group, I don't really need to introduce the leading causes of pregnancy-related deaths. This is slightly older CDC data showing that cardiovascular conditions and cardiomyopathy combined accounts for almost 1 in 4 deaths that occur as a result of pregnancy, either during pregnancy or the postpartum period. And when we look specifically at the postpartum period, cardiomyopathy is the leading cause of death, especially when we look at the time period from 7 days to the end of 1 year. Now, of course, more recent data, which includes substance abuse, eclipse the cardiovascular conditions as the leading cause. But I will say that if we specifically look at Black birthing individuals, that cardiovascular conditions is still the leading cause of death. And that is also reflected here in this slide, looking at using the same type of data, we see that Black individuals are more likely to die from cardiomyopathy, preeclampsia and eclampsia, and embolic causes, really highlighting the impact to mitigate racial disparities in outcomes if we improve our diagnosis and treatment of cardiac conditions. Recent learnings from maternal mortality review committees have given us several lessons, which I think is relevant to this topic. The first is that the majority of deaths are preventable, and that does include deaths from cardiovascular disease. Over half of deaths occur 1 week or later after delivery, when most people have been discharged from the hospital. And most individuals who die from cardiovascular disease have no prior diagnosis of cardiovascular disease. And I think that's really important to emphasize. It could be because they have a new condition that presents during the peripartum period, or perhaps they were previously undiagnosed. And so even though I always like to briefly review the physiologic changes of pregnancy and how that can unmask underlying cardiovascular disease, this may or may not apply to people who don't have cardiovascular disease going into pregnancy. But just to briefly review, we know that cardiac output increases up to 50% during pregnancy and peaks in the second trimester. And this increase in cardiac output is driven both by an increase in stroke volume and heart rate. We often talk about how the plasma volume peaks at around 32 weeks of gestation. So for my pregnant patients coming into pregnancy with heart disease, we often talk about this as a time when many people will develop symptoms if they were previously asymptomatic. And we know that the decrease in systemic vascular resistance is greatest in the first 2 trimesters. And so it's really in the 3rd trimester that vascular resistance starts to increase and the blood pressure starts to increase back to baseline levels. Now, I wish I could show a similar graph of what happens after delivery, but I haven't quite found the perfect figure to share yet. The residents and fellows that work with me know that I often talk about the fact that the postpartum period is when I most start to worry about our patients. I feel like a lot of our patients are followed very closely during pregnancy, and then they deliver, and follow-up can be really hard for a lot of people. People who develop new symptoms might present to hospitals or healthcare settings that don't actually take care of pregnant people on a regular basis, and so may not be as accustomed to dealing with pregnancy complications. Um, so I'm going to go ahead and start with my first case. I have 4 cases to go through today. This first case is a 35-year-old woman presenting with shortness of breath. She has a history of hypertension, obesity, and obstructive sleep apnea. And she's coming in with dyspnea on exertion for 1 week that's been progressive. She has a 6-year-old that she's been walking to school, and she notices that it's been getting harder and harder to keep up her pace, walking him to school every day. She also complains of a dry cough, orthopnea, and some leg swelling, worse on one side. And she presents to the emergency room. And in the emergency room, she doesn't have a fever. She's hypertensive, tachycardic, but her oxygen saturation is at least normal on 2 liters. And she looks unwell. She has increased work of breathing. She has some faint rales at the bases of her lungs. She does have some lower extremity edema, but no murmurs, and her GVP on exam was not well visualized. She ends up getting a CAT scan. She gets a chest x-ray, which is abnormal, which leads to a CAT scan to look for pulmonary embolism, which she does not have. But her CAT scan suggests possible bilateral pneumonia. And the reason I like to start with this case is because there's some key information that's missing from her presentation. The first is related to her history. Oop, let me just stop. Oop. Sorry about that. The first is related to her history, which is that she's 6 weeks postpartum. And that information wasn't collected at triage. And it wasn't something that was volunteered by her on her initial history. But the resident seeing her did get an OB history and found out that she was postpartum. And given their suspicion for cardiac disease in the postpartum period, they also ordered what's called a BNP, or an NT-proBNP level, which was quite elevated. And we'll talk about this a little bit more in a few slides. And so given that, they had an increased suspicion for heart failure, and they got an echo, which showed severe enlargement of the left ventricle and severely reduced function of the left ventricle, with the EF, the ejection fraction, being 20%, as well as reduced function of the right ventricle. And so I always start with this case to highlight the importance of taking a pregnancy history in all pregnancy-capable individuals. In the emergency room, it can be life-saving. And then in our primary care and cardiology clinics, it really helps us understand the future risk of cardiovascular disease for those who've had pregnancy complications like preeclampsia. In terms of how we diagnose peripartum cardiomyopathy, there are criteria that have been published for several years and have been shared in these guideline documents that I have listed on the right-hand side. And the criteria include new onset of heart failure with an ejection fraction of less than 45%. The timing of diagnosis, it occurs towards the end of pregnancy or in the months following delivery, which is really nonspecific. And I think that's intentional because we don't know. We don't know exactly when someone can develop peripartum cardiomyopathy. We have a patient who's currently admitted who developed preeclampsia and heart failure at 33 weeks of pregnancy and then delivered. So technically she did deliver towards the end of her pregnancy and was diagnosed. And then we also diagnose it in the setting of no other cause of cardiomyopathy. I have this little text at the end, which says the left ventricular size is often dilated, but not always. On this slide, I have some information about the timing of diagnosis. So we talked a little bit about diagnosed towards the end of pregnancy or in the months after delivery, but in reality, many people are actually diagnosed in the early postpartum period, within 1 to 2 weeks after delivery. Some people might even present within hours after delivery. But this is work that we've done at my institution at Penn Medicine, where we looked at individuals diagnosed with peripartum cardiomyopathy over a 20 to 30 year period. So this is retrospective in our electronic health records. And what we saw is that in our population, where we serve a predominantly mixed white and Black population, that women who were non-Black, which is predominantly white here in Philadelphia, were largely over about half of them were diagnosed within a week, and smaller percentages of people were diagnosed 1 month or a few months after delivery. But when we looked specifically at Black individuals, they were disproportionately diagnosed later in the postpartum period. And I wanted to highlight this because this work demonstrated that late diagnosis, so 4 to 6 weeks after delivery, is associated with worse long-term outcomes, and Black patients disproportionately experience delayed diagnosis. So one of the reasons why I care so strongly that we're thinking about cardiomyopathy and heart failure and making the diagnosis early. I mentioned that in order to be diagnosed with peripartum cardiomyopathy, we use the results of the echocardiogram. However, a simple blood test called the BNP level is widely available and also helps identify heart failure. This is true in non-pregnant or peripartum patients, and it's also true in pregnant and postpartum patients. And that's been shown in a number of studies, which have looked at what we call BNP levels throughout pregnancy. And as you can see in the graph on the right, the BNP levels are stable in the first, second, third trimester, and even at the time of delivery. And all the values shown here on the right are within the range of normal. So the levels, you can interpret a BNP level during pregnancy. Now, it may increase in the setting of preeclampsia. You can see that in mild preeclampsia, it's a little bit elevated, and it's more elevated in severe preeclampsia. Um, but we also know that preeclampsia can cause to volume overload and some pulmonary edema as well. And so certainly if someone has preeclampsia and an elevated BNP level, we should be thinking about cardiac causes, cardiac complications in these patients. Now, one of the limitations of using this BNP test is that obesity, it is not always accurate in individuals who are obese. And so you're more likely to have a false negative in someone who is obese, meaning your BNP level could be normal, even though someone has heart failure. So if you see a high level, then you have a very high index of suspicion for heart failure, but a low level can sometimes be confusing, but this is the case, the same as a non-pregnant population. This isn't specific to peripartum patients. And, just to sort of continue with, how we think about how we diagnose, how we treat peripartum cardiomyopathy, I do want to highlight that a lot of these patients do improve and have good outcomes, but serious adverse events still occur and contributes to cardiomyopathy being a leading cause of maternal mortality in the postpartum period. So our largest study, prospective registry of patients with this condition, was the IPAC registry, which enrolled 100 patients, and about 70% improved at 1 year to normal or almost normal heart function, but 13% experienced a serious adverse outcome, including death, needing a heart transplant, needing mechanical assistance to support the heart function. And Black patients had lower rates of recovery compared to non-Black patients. Now, there certainly have been many cohorts, retrospective cohorts, published, some of which have shown lower rates of recovery. And I think overall this varies by population and geography. I think someone might be unmuted. If you don't mind muting yourself, please. The figure on the right, thank you. The figure on the right shows the outcomes of patients with peripartum cardiomyopathy based on how severe their disease was at diagnosis. And you can see on the left-hand side, those who had an EF of less than 30% at the time of diagnosis were less likely to have a full recovery, which is shown here in purple, compared to those who had an EF of greater than 30%. And so early goal-directed medical therapy is critical to promote recovery. And this is true for peripartum cardiomyopathy, but really any new cardiomyopathy diagnosed related to pregnancy or unrelated to pregnancy. As you can see here, if someone is postpartum and they're not lactating, we can use any of the goal-directed medical therapy treatments that are available. But in patients who are lactating, I just want to provide reassurance that we can actually use most of our evidence-based medications that will help people feel better and improve their heart function. So beta blockers, spironolactone, hydralazine isosorbide are all safe to use in lactation. And we can even use some ACE inhibitors or ARNIs as well, including captopril, enalapril, and maybe even Entresto. There's new data that this is also safe to use at low doses during lactation. SGLT2 inhibitors are our newest class of medicines we use in patients with cardiomyopathy and a low EF. And so far, these are not considered to be safe during lactation. This talk focuses less on the treatment of heart failure during pregnancy, but you see that we run into more issues with having medicines that are safe to use during pregnancy. And before you roll your eyes at this at this figure, I know there's a lot going on here. I just want to say that one of the therapies that we're currently investigating to see if it also helps to improve outcomes in peripartum cardiomyopathy is bromocriptine. And so I put this figure up here on the right to demonstrate that one of the ways that this medicine works is by suppressing release of prolactin from the pituitary gland. So prolactin is what we need to lactate, but it may be implicated in the pathogenesis of peripartum cardiomyopathy. So there have been mouse studies showing that it can be used to reverse postpartum cardiomyopathy. And there have been early studies in humans showing that it's safe and showing promising efficacy, but we don't have a placebo-controlled randomized clinical trial. And this is just information to let you know that there is one. There's a randomized trial going on so that we can understand whether bromocriptine can help our patients with peripartum cardiomyopathy. And so I just wanted to share this information here. Just to get the word out, and in Georgia, Emory is an enrolling site with Dr. Lakshmi Sridharan, who I don't know personally, but has been enrolling patients in the study. And then one other resource, and this is the work that I've been involved in, is something called the Peripartum Cardiomyopathy Registry. And so this is a QR code that takes you to our website. And myself and colleagues at Penn and University of Wisconsin have developed educational resources for patients and clinicians. And it's also an online research registry. So patients can enroll themselves online. They don't have to travel to an academic medical center to participate in research. And so our goal is to understand more about this condition and make research accessible to a more diverse patient population. And so I also want to say that not all postpartum heart failure is caused by peripartum cardiomyopathy. But the approach to diagnosis and treatment is similar, regardless of the cause. I have a patient who we diagnosed with a cardiomyopathy, so a low ejection fraction, during her recent pregnancy. Her EF was mildly reduced. It was 45%. She was asymptomatic. She also had high blood pressure, but otherwise did really well during her pregnancy. Her mom has a history of cardiomyopathy and was very, very sick at one point, and was on a heart transplant list, but eventually got better with medication, which is amazing. And so, there was some anxiety around what would happen with her pregnancy, but she did really well. And at around 6 weeks after delivery, she developed heart failure. And she was admitted to the hospital, and her echo looked worse. Her heart function had gotten weaker. And again, I don't think this is peripartum cardiomyopathy. I think this is worsening of her underlying heart condition. And I don't know what it is at, 6 weeks that changes that leads to a heart failure to compensation. And so I think it's this very vulnerable, the fourth trimester is this very vulnerable time for these patients, whether it's related to biology, whether it's related to social situation, and other factors that they really need close follow-up. All right, I'm going to transition to case two, which is a case of chest pain after delivery. This is a case of I think the last patient was also 35, a 35-year-old woman who is 2 weeks status post full term vaginal delivery. She has no past medical history, no history of cardiovascular disease. She's a non-smoker. She's G4P4, no history of preeclampsia. And she's coming into the emergency room with chest pressure. So she initially had it last night. It lasted 20 minutes while sitting on the couch watching TV. She went to bed. She was able to sleep through it. It got better, I think. However, when she woke, oh no, it woke her from sleep. I apologize. So it recurred overnight and woke her from sleep. And that was what scared her. And so she presented to the emergency room. And so, as we think about the differential diagnosis for chest pain, I'm sure many of you are familiar with this, especially in someone who's recently postpartum. We're thinking about pulmonary embolism. Other cardiac or vascular causes include myocardial infarction, aortic dissection, myocarditis, as well as cardiomyopathy. But then there's plenty of non-cardiac causes that may also be involved, including respiratory infection, GERD, or musculoskeletal causes. And this is just to highlight that these three conditions all have elevated risk in the postpartum period. So even though each of them is uncommon, it is going to be more common to develop it postpartum than someone who is not recently postpartum. This patient had an EKG, which is shown here. And just to highlight that she has T-wave inversions in the anterolateral leads. So this is a very abnormal EKG. And so they checked her troponin levels. And at first they were negative, but then they became positive, suggesting that she had acute coronary syndrome or an NSTEMI. And this is to highlight that cardiac catheterization is the gold standard for diagnosis of acute coronary syndrome, certainly for STEMI, but as well as NSTEMI. And this is true in postpartum patients as well. And I bring this up because this patient did not get sent for cardiac catheterization initially, and she also didn't get a workup for acute coronary syndrome. However, after she was discharged, she came back to our institution with recurrence of her symptoms, and she did get a cardiac catheterization, and it showed that she had a spontaneous coronary artery dissection. And so what I show here on the right is a snapshot of her coronary angiogram, and the red arrows are pointing to where we should be seeing her left anterior descending artery. You can only see a little sliver of it right here, and then it disappears. And then the white arrows show the proximal part of the artery, which we can see, but it is significantly stenosed. And so she had a very, very large anterior wall myocardial infarction. And so SCAD is uncommon, but I am going to talk about it briefly so that you're familiar or more familiar with the terminology. It occurs when a hematoma or blood clot forms within the wall of the coronary artery. So this is what we call an intramural hematoma. So the blood clot is between the two layers of the lining of the vessel wall. And then the bigger the hematoma gets, the more it compresses the true lumen, and so blood cannot travel down the vessel. You can sometimes get a tear in the vessel wall as well. So that's called an intimal tear. And SCAD is an important cause of acute coronary syndrome in younger women, and as I mentioned, is diagnosed on cardiac catheterization. So if we look at all patients presenting with acute coronary syndrome, only about 1 to 4% will have SCAD, although as you can imagine, it's difficult to estimate what the true prevalence of the condition is. But if we look at women who are 50 years or younger presenting with acute coronary syndrome, up to a third will have SCAD. And if you look at pregnant or postpartum individuals with acute coronary syndrome, one study showed that 43% of them will have SCAD. So there seems to be some predilection for women and the pregnant and postpartum state, but we haven't quite figured out why that is the case. And then the mean age at the time of diagnosis is 48 years old, but I've certainly taken care of teenagers up to people in their 80s with this condition. Now, luckily, pregnancy-associated MI is myocardial infarction is uncommon, but it is underdiagnosed. And when someone presents with a SCAD, a heart attack from SCAD in the peripartum period, it tends to be more severe than SCAD that does not occur as a result of pregnancy. The figure at the bottom shows the timing of when we most likely see the diagnosis. And you can see that most people are diagnosed within the first 5 weeks after delivery, with many of them even diagnosed in the first week after delivery. So it doesn't look that different than the timing of diagnosis for peripartum cardiomyopathy. So maybe I'm getting you to understand where my anxiety comes from once our patients deliver and get discharged from the hospital. We don't have too much time to go into how we manage the condition, but I just want to say in contrast to how we manage heart attacks from atherosclerosis or plaque buildup, we don't often put a stent in patients who have SCAD, and that's because it often heals, the hematoma heals on its own. And so this is one of our patients who initially presented with SCAD of this left circumflex artery. And a few years later, she came in with SCAD of a different vessel, but this artery looks completely normal. And so that's a remarkable recovery. And so sometimes we do have to put in stents or send someone for surgery to help the heart. But if we can avoid it safely, we usually try to do that. And then this is just to highlight that, peripartum individuals can also have myocardial infarction from atherosclerosis or other causes. Of course, it's uncommon, but it still occurs. This is another one of our patients who was 36 years old, who had a history of hypertension, high cholesterol, and a family history of premature coronary artery disease. And she is G1P1 and was 3 months postpartum and breastfeeding when she started to develop exertional chest pain, which was escalating or progressive. So it started to come on with less and less physical activity. And the day she presented, she actually had an episode at rest. In the emergency room, her troponin was negative. So it wasn't clear if she was having an NSTEMI or acute coronary syndrome, but her EKG was abnormal and she was sent to the cath lab and she had this discrete lesion here, which is more consistent with what a blockage from atherosclerosis looks like. And on her tests, her LDL, which is her bad cholesterol, was 181. And so she had previously undiagnosed familial hypercholesterolemia, that was her major risk factor for developing atherosclerosis at such a young age. So now I'm going to transition to case 3. I think we're doing okay on time. Are there any, should I pause to ask if there are any burning questions now, or should I just continue and finish the last 2 cases?
I think we can advance on. I think we're good.
Okay, great.
Thank you.
So for case 3, this is a presentation of shortness of breath and chest pain postpartum. So this is a 36-year-old woman who's only 5 days after vaginal delivery. She has a history of asthma on inhalers. She is G6P4 and was induced at 34 weeks for severe preeclampsia. And she's coming in with dyspnea, squeezing chest pain, and palpitations. Her heart rate when she came in was 150 beats per minute, so quite tachycardic, but had a normal blood pressure and oxygen saturation. And unlike our prior two cases, her BNP and troponin levels are normal. And so she was sent for a CTA of the chest, which showed acute pulmonary embolism. And pulmonary embolism in the postpartum period, well, I should say pulmonary embolism overall has low incidence, but the risk increases during pregnancy and it really peaks in the early postpartum period. And I feel like this is something that was like burned into my brain in like medical school, is that I was always taught to, think about PE and someone presenting with tachycardia or chest pain or shortness of breath in pregnancy or the postpartum period. We often use in non-pregnant people D-dimer levels, but those can be less reliable during pregnancy. And risk factors specifically for PE in the peripartum period are a prior history of thrombosis, thrombophilia, older age, C-section, and obesity. And the symptoms are listed here. And so it seems like it might be easier to, make a diagnosis of PE, given that we hear about it so often, but we know even for very famous people who are having symptoms of PE and who have a history of PE, early diagnosis can still be challenging. And this is to highlight other cardiovascular diseases in the postpartum period. On the left, I have a few facts related to aortic dissection, which luckily is rare, but there is an increased risk in postpartum individuals versus non-peripartum individuals. Risk factors are having connective tissue disease, such as Marfan syndrome or hypertension. And about 40% of patients who have connective tissue disease are unaware of their diagnosis prior to their dissection. So if you know someone is coming into pregnancy with Marfan syndrome, you're going to be getting an echo or CT or MRI scans and following them very closely. But unfortunately, almost half of the people coming into pregnancy with a connective tissue disease are unaware of their diagnosis. And other causes of cardiovascular complications after delivery include other types of cardiomyopathies, arrhythmias, which we haven't talked about in great detail, but we can certainly talk about in the discussion section, valvular heart disease, especially mitral stenosis from those individuals with a history of rheumatic heart disease, congenital heart disease, and then pulmonary hypertension, which is another condition that can be undiagnosed prior to coming into pregnancy. And so I'd like to finish up our last case with a presentation of headache and shortness of breath after delivery. This is a patient who is G1P1, just with a history of obesity, and had an induction at 37 weeks due to preeclampsia. She was discharged on furosemide or Lasix for 20 milligrams for 5 days. And that's actually our protocol at our hospital for all individuals with a hypertensive disorder of pregnancy, since some studies have shown faster resolution of blood pressure on this regimen. But she was readmitted on postpartum day 5 with headache and shortness of breath. And I forgot to write hypertension, but she also is hypertensive. And her chest x-ray showed mild pulmonary edema. So she had an echocardiogram, which showed normal function of the left ventricle. And so I put up this information here, which alludes to something that I mentioned earlier, which is, of course, that postpartum patients may be seen in care settings that are not accustomed to treating pregnancy complications. And so we can all be advocates, both by educating our patients prior to delivery and advocating for their workup once they are seen elsewhere. Just because I feel like in some of the hospitals that I've worked in, someone coming in postpartum with preeclampsia is the evidence-based guidelines are not always followed. And so in our institution, we have studied some strategies to improve postpartum blood pressure monitoring. Would love to hear what you all do in your practices, but we actually use a texting program, which was found to be acceptable and feasible as a way to monitor postpartum blood pressure. So all patients with hypertension are enrolled in this program where they get daily reminders to check their blood pressure twice a day for 10 days after delivery. They check their blood pressure at home, and then they text in what their blood pressure is, and all of that is integrated into our electronic health record, which is pretty amazing. And so compared to office visits, telemonitoring has been associated with improvements in actually conducting blood pressure monitoring, a reduction in racial disparities in blood pressure monitoring, higher rates of postpartum OB visits, and lower hypertension, fewer hypertension readmissions. And so one question that always comes up is, well, what is the optimal blood pressure goal after delivery and the weeks after delivery to prevent acute complications? And, to be honest, it actually hasn't been well studied, but I think there is a renewed interest in this area of research, especially after the CHAP trial was published a few years ago. And a lot of my work and research is focused on, how do we prevent hypertension from developing after a hypertensive disorder of pregnancy? How do we prevent cardiovascular complications of hypertensive disorders of pregnancy years or decades down the road? And I think the early diagnosis and treatment of chronic hypertension is key to that. And just to, emphasize that for young individuals without heart disease, we are starting meds and promoting lifestyle changes in those with stage 2 hypertension, which is a sustained blood pressure greater than 140 systolic or greater than 90 diastolic. And then people in the stage 1 hypertension range, where their blood pressure is 130 to 139, or the diastolic is 80 to 89, are kind of in this at-risk is this at-risk group where we can talk about the risk benefit of whether medications are needed. And so this is just a review of our cardiac symptoms not to miss. So for shortness of breath, this is especially relevant to our patients during pregnancy because it's obviously so hard, to tell if the shortness of breath is related to the pregnancy or is it pathologic. And I don't always know either, right? And so that's why I'm lucky to have access to testing to help figure it out. But someone who has dyspnea at rest, who is describing dyspnea that's significantly worse than prior pregnancies, if they've had prior pregnancies. Many people during a healthy, normal pregnancy will describe feeling winded when they climb a flight of stairs, but most people won't need to stop before they reach the top of a flight of stairs, if they were able to do that normally before pregnancy. Dyspnea or edema that worsens after delivery, I think that's like one of the things we most commonly see. Tell people they should be feeling better, not worse after delivery. And then, of course, any of our objective signs that we measure. And for chest pain, I put discomfort in parentheses because a lot of people will say, oh, it's not pain, it's more of a discomfort or a squeezing sensation or something else. But these all get grouped together under the rubric of chest pain or discomfort. Chest pain that's exertional, that improves with rest, is always concerning for angina. Sudden pain at rest lasting more than 5 minutes. Someone who's having chest pain with associated symptoms of, I just feel like something isn't right. I think that can be a very ominous sign that something is going on. And then, is anxiety causing chest pain or is pain causing anxiety for those people who are having both chest pain and anxiety? And honestly, it can be very difficult to tell. And so you can treat the anxiety acutely and see if their chest pain gets better. Or you can make sure you do a cardiac workup so that you're not missing anything. And I did want to finish on some of the work that the CMQCC has developed looking at cardiovascular risk algorithm and suggested workup. And this is work that Dr. Afshan Hamid has done, who's giving, it sounds like grand rounds tomorrow. She's a a phenomenal clinician and researcher, and I've learned so much from her and this is work that she participated in. And it sort of suggests, what are the signs and symptoms that we should be looking at during pregnancy or the postpartum period to order testing to look for cardiac disease. Now, of course, in people who have red flag symptoms and have a personal history of cardiovascular disease, that's a different population. These are people who don't have any of those red flag symptoms. And so looking at a combination of symptoms, vital signs, risk factors, and exam findings, if someone has a combination of these that adds up to 4 or greater, it suggests that they should undergo further testing. And when in this work, they've looked at, in patients who ultimately died as a result of pregnancy, almost all of those patients would have been picked up by this algorithm. And so this is work that we're currently implementing at our institution and trying to understand some of the barriers, both on the patient side, the provider side, and the health system side, barriers to implementing it. So in summary, we talked about that cardiomyopathy is the leading cause of maternal deaths after delivery, that the BNP level is a helpful tool to diagnose heart failure in addition to echo. An abnormal EKG and positive troponin is acute coronary syndrome until proven otherwise. And blood pressure telemonitoring programs after delivery may improve clinical outcomes. And so I just want to thank you all for your attention and happy to answer questions now, or feel free to reach out to me at any time with questions. And I'm going to put in a shameless plug that we're developing some quick reference materials for clinicians and would love feedback. And so if anyone is interested in looking over some of our one-page PDFs and giving their quick feedback, feel free to reach out as well. I hope that's okay. So I'm going to stop sharing my screen and hopefully there are questions that we can talk about.
Wonderful, wonderful presentation. Thank you so, so much. Got one question that has come into the chat, Dr. Louie. So for the patients that are discharged home with a 5-day prescription for Lasix, do you also prescribe a short-term script for potassium?
Oh, that's a great question. Thank you so much for asking it. So this was a point of, so my collaborator designed the study, and so this was a point of debate early on when we were designing the protocol, because as a cardiologist, I was like, oh my gosh, we have to like give everyone potassium as well. And so it was one of the things that we studied during the trial. We didn't give people potassium, and there were no cases of clinically significant hypokalemia. And so we actually don't give potassium in those patients. Now, in people who happen to have their potassium checked and we notice that it's low, that's a different story, but it is not part of the protocol.
Thank you. Any other questions? Feel free to come off mute.
I have a question. This is
Go ahead,
Ashley.
Ashley.
With the at-home blood pressure monitoring where the patient checks their blood pressure, forgive me if I missed this, do you know if it's a manual process to put in the data or does it go straight into the EMR? And if so, what software do you use?
Mm-hmm. So the question that you have is if the patient checks their blood pressure, how is it imported into the electronic health record?
Yes.
So we have a platform at our institution called Way to Health. It's this like web-based platform that synchronizes sort of digital technology with the electronic health record. And so for this program, and actually we have other programs in non-pregnant individuals, the text message that is sent out to the patient is like automated by this platform. And then all of the blood pressures are automatically updated both into the platform, but also into Epic, which is what we use here. And so that is like a pretty awesome tool to have at our disposal, because you can imagine if it didn't happen that way, how else would you be monitoring all these blood pressures? And so other institutions also have access to Heart Safe Motherhood. Like it's something that's provided to other institutions, not just Penn, across the country. But I do know that other places use, I feel like Baby Scripts also has like a similar program, although I don't know if people are texting the blood pressures or whether it's paired to a Wi-Fi or Bluetooth enabled device. For our population, texting was more reliable because not everyone had like Wi-Fi or Bluetooth availability. And so we just felt like that was the easiest thing to do for the most number of people. But I know different programs do different things.
So with that, if there's an identified, say they take a couple of blood pressures, they text those in and they're elevated, what's the process for following up?
Yes, thank you for asking that follow-up question. So as part of the algorithm as it currently stands, if the blood pressure is greater than a certain threshold, it sends an alert to the covering clinician. And so we have different protocols for different hospitals. Here at the hospital I'm at right now, the covering clinician is the maternal fetal medicine doctor on call. At another hospital site, it's a nurse practitioner during daytime hours, and at night, it's the labor and delivery team. And so, if the blood pressure is greater than 160 over 100, I believe, there's that automated response. And then the covering clinician reaches out to the patient to talk about symptoms, discuss either starting a new medicine or changing medicine at home, or whether someone needs to come in to the hospital to get evaluated. But blood pressures that are not in the severe range are not actually like acted upon unless people notice a trend when they sign into the platform and look at the trends. We're doing a pilot study now to see what it would look like to, target a lower blood pressure goal and the different ways to do that.
Dr. Louie, have you guys worked with your emergency departments in cases just like that? So you have a mother that's had several elevated blood pressures and they, get contacted by the on-call provider. The on-call provider screens and say they determine, yes, they need to be seen in the ER. So is your ER informed one to screen all pregnant and postpartum women? And are there standing protocols working with the ERs on cases like this?
Okay, so that is a wonderful question, and I may not be able to answer it completely as a cardiologist. I mean, obviously, I work very closely with my OB partners, but I don't know all of the details of the protocol. But what I can share is that at our two hospitals in downtown Philadelphia, there is I call it like OB urgent care, but it's the perinatal evaluation center. So all of those patients are presenting to the perinatal evaluation center, which is run by the OB service. And so I think communication is a little bit easier there. That being said, there are a number of hospitals in our larger network in our health system that don't have that resource, and there have been issues in the past with how to manage these patients. And so I know algorithms have been developed with the different emergency rooms in those cases. One of the things that came up as part of that and some of the misses or near misses is that pregnancy history wasn't being asked as part of like the triage assessment. I'm not sure we've like fixed that completely, but one of the things that we've changed to Epic, our electronic health record, is that if someone was recently pregnant, there's like an icon that does pop up. Well, if they are pregnant, it pops up, but it also pops up if they were recently pregnant. Now, whether everyone pays attention to it, because there's like so much on the electronic health record, that's another question. But I think it's an area that's currently being examined. And then I'm meeting with the ER folks, later this week to talk about what our cardiovascular risk screening algorithm looks like in the emergency room as well. So I think we're still trying to figure out how to implement these systems of care.
That's awesome. We're doing the same here.
Oh, great. I would love to hear.
Chris had a question. She says, do you prescribe anticoagulants during the postpartum period for obese patients?
I don't, unless they have a history of a thromboembolic event. Is this something that you do routinely?
Chris, feel free to come off mute if you'd like.
everybody. Can you hear me okay?
Yes.
Ma'am.
Okay, perfect. I'm driving to Chateau Alon, so I just want to make sure. So we had a recent event where a patient had developed a PE, and high risk factors included obesity, preeclampsia, and an IUGR baby. So we're trying to have some sort of guidance where ACOG says they recommend a screening tool for VTE in the immediate postpartum period, but do take into consideration severe risk factors in treating those patients with said risk factors in the postpartum period as well, with either Lovenox or heparin, or just to prevent. And we just wanted to see, is this something that other areas of the country are looking to do as well?
Wow, that's a really great question, and I hope the patient, ultimately did okay. But, it's not something that I've seen in clinical practice. I feel like our rate of hypertensive disorder of pregnancy and obesity and advanced maternal age is so high. That would be a not insignificant proportion of the population. But, I can't speak to more than that. As a cardiologist, it's always interesting to me how the OB clinicians use prophylactic dosing of Lovenox during pregnancy or the postpartum period, which is not something we use a lot of in cardiology. Like either you're on therapeutic dosing or not. But I think that would be a really interesting question to study.
Thank you.
Thank you. And we are at 3:00, so thank you for a magnificent presentation, Dr. Louie, and for taking time out of your busy schedule to share what's going on in your world and help educate us and move us in the right direction for our hypertension and cardiac initiatives. So we greatly appreciate that. Everybody
Thank you so
else,
much for the opportunity. I appreciate it. Bye, everyone. I hope everyone stays safe from the hurricane.
Thanks. And thank you, everybody else, for taking time out of your busy schedules as well. I will send a follow-up email by the end of this week with any resources from today's webinar, and a reminder that the webinar will be available on our website and on DPH's YouTube channel in the next week for sharing or reviewing. Reminder to make plans to join us November the 5th for our next GAP-QC maternal webinar with guest speaker Christy Gable. Thanks and have a wonderful rest of your day.